So for the meeting benefit, if everyone can keep the camera on where possible, that'll be great, so we can see who we're talking to, and I can see many of you do have your cameras on. If you can stay on mute for the majority of the presentation, and at the end there will be some time for questions, and anyone and Andy as well, if we can avoid using any acronyms and abbreviations for the benefit of those who may not know what they are. Okay, so for those who don't know, we regularly hold membership virtual events. The events are always held via Teams, as you can see there, last for around an hour, include a short presentation and then 5 to 10 minutes for questions at the end. And we will, at the end of the today's presentation, send out an electronic feedback form. So if everyone could fill it in and return it, that would be fantastic, because it helps me then plan future events. I won't go through this. Everyone knows we're a specialist hospital. I will go through about the membership quickly. So for those who have had the link shared with them through friends and family, if they do want to sign up to the Walton Centre membership, you're more than welcome to do that. It is free, and the only requirement is that you're over 16. And a lot of the people who do join our membership are members of the public, past patients and family members of patients. For our staff, we're automatically enrolled as members of the trust on signing our contract. So our membership base is our staff members and public, and they'll be on the call today. We do have the QR codes on screen. If anyone does want to join the membership, they can, or they can drop me an email and I can forward on the information for you. So that is pretty much it from me. I am going to hand over to Andy, and I'm going to stop sharing. And yeah, there you go. Thank you, Andy.
Okay, thank you very much. And thank you very much, everyone, for coming. I'm Andy Brodbelt. I'm a neurosurgeon here at the Walton Centre. When I was asked to do this talk, I was initially asked to talk about my career, but I thought that would just be really boring. During COVID, I suggested to the comms people that a Tales from the Walton Centre, or just Walton Stories, would be an interesting project. I feel the real stars of the Walton Centre are our patients. What they have to deal with and how they deal with it can be truly inspirational. So I thought I'd talk about some of the people I've known and been involved with in their treatment over the years. I then started putting this talk together. It was actually quite a lot harder than I thought it would be. I also found people who were actually going to come to it, so I had to actually do something properly. But what I've tried to do is try to appeal to both clinical and non-clinical people, governors, and of course patients. In the end, I thought this talking about some of the patients I've been involved with and a bit about how they think about things might be of interest. I need to add right at the beginning that this is a team event. It's not just me looking after these people. We have a good team here. Colleagues who are supportive, but also tell me exactly what they think. Trainees who also tell me exactly what they think. Specialist nurses, staff, allied health professionals, my secretary, the secretaries who do stuff when my secretary's off, support staff, and even the off-the-line managers. I must also mention my wife, Catherine, who has always been very supportive and gives me absolutely no sympathy, which she tells me is a good thing. March is National Brain Tumour Awareness Month, as is the specialty I deal with most is people with brain tumours. Many of these stories concern people with brain tumours. Due to patient confidentiality, I've changed people's names as we go along. I remember the first week, my first week as a new consultant. I was appointed as the lead in neuro-oncology, which means surgery for people with brain tumours. I saw a patient that week, a lady about 50 years old. Gillian had breast cancer that had been treated a few years ago with surgery and radiotherapy. She'd been on drug treatment to try and keep any cancer cells at bay. After she developed headaches and weakness in her left arm, a scan showed a brain tumour with some swelling. It was likely this was a cancer, and because of her history, it was likely this was cancer related to her previous breast cancer. I saw Gillian in the clinic and chatted to her about things. I told her if we leave things alone that this would be life-threatening in only a few months. The other options included that we could give her radiation treatment, and that would keep her alive a bit longer, or we could offer her surgery to remove the cancer, followed by radiotherapy. I explained that surgery cannot remove all the cancer cells, as when people do operations for cancer in other parts of the body, the surgeon will normally take the cancer and a cuff of normal tissue from around the cancer to remove any cancer cells that have spread in the surrounding brain. The surrounding tissue. I can't do that in the brain, hence why radiation treatment is often used to stop these cancer cells growing again. This doesn't cure people, but people can live a long time after this sort of surgeries in years. I went through the risks of surgery. Gillian was a bit scared, but she seemed willing to consider an operation. She then asked me how many of these operations I had done before. It was my first week as a consultant. It was like day 3. So the answer was 0 as a consultant. I didn't say that. I'd done a number as a trainee, but I had no idea how many. So I panicked and I said, "Oh, about a dozen." She stopped, looked at me for a while, and then seemed mostly okay with that. Surgery went fine, the cancer came out, and she was well, her arm was better. 3 months later, at our final appointment, she gave me a teapot that she had painted as a gift. On it, it said, "Lucky number 13." Strangely enough for a surgeon, I've had and have several patients who have not let me operate on them. In looking after them, they've taught me about themselves and the treatments we provide. I remember a man of 60 who had a large low-grade glioma. This is a tumour that is slow growing, arises from the supporting cells of the brain, and mixes in with the normal brain cells. The tumour can sometimes become cancerous, but this does not always happen. The average life expectancy of someone with his particular type of tumour is 5 to 7 years with treatment. We would normally treat it with surgery to remove as much as possible, then give radiotherapy and sometimes chemotherapy. David's tumour had been found incidentally. He had had a scan and there it was. He came to see me and we talked about the options. He had no symptoms. David was the director of a company and wanted to drive and keep working. Having surgery would put a stop to that for a year or two, and further treatments would stop him working for at least a period of time. This was not a tumour I could remove. It was too extensive. All I could offer was a biopsy to allow him to go for further treatment. Often we use radiotherapy, although some types of chemo can sometimes help with these types of tumours. He elected to have the tumour watched, so I would meet with him every 6 months initially, then every year. We watched together as the tumour slowly got bigger until it was mixed in with most of one side of his brain and was starting to spread to the other. He had no symptoms and continued working. Eventually, after almost 10 years, David started to become confused and the tumour finally started to affect him. By then, it was too late, and unfortunately he passed away less than 6 months later. And you might think this is simply a sad story of someone missing out on treatment. In fact, I would suggest the truth is quite different. The tumour was always likely to kill him, whatever we did. He lived a normal life, or most of his life, with it. If I had done a biopsy on him 10 years earlier and then went on to radiotherapy, it's unlikely that he would have remained as well as he did because of the size of the tumour and the amount of brain that would have had to be irradiated. I've seen people over the years after extensive radiotherapy to the brain who start to deteriorate cognitively by 4 or 5 years. They lose their memory, their drive, their energy. David kept his dignity. He was able to work and lead his company and do what was important to him. It made me realize that in some specific situations that sometimes our treatments are worse than the natural history of the tumor, and what was important to him was quality of life, and he had 10 good years. One of my other patients, Carol, who wouldn't let me treat her, was a woman who also had a low-grade glioma. Carol's tumor was discovered after she was treated for a brain aneurysm. Her tumor slowly got bigger. This was in an area that could be operated on, but was near one of her speech centers. Carol didn't want surgery, worrying that it would affect her ability to talk. Again, like David, we watched together as her tumor got bigger over time. Unfortunately, in Carol's case, her tumor became cancerous. She traveled the world doing a lot of things that she always wanted to do and tried alternate treatments. We would meet regularly. She would have a scan and we spoke about surgery. She was always extremely grateful to me and even wrote to the king saying nice things. I didn't hear back from the king, as I'm sure he's very busy, and I don't know if she ever did. She never did agree to surgery in the end. Carol dealt with the tumour in her own fashion, and this allowed her to keep control. Carol lived every day of her last few years as if that day was her last, and she really enjoyed her life. I think our regular meetings help. I could not have cured her tumour. I could have only slowed things down a bit, but might well have made her speech worse. This might seem an inefficient use of the NHS and its resources, but maybe sometimes surgical care doesn't always involve doing an operation. For both David and Carol, quality of life was the most important consideration in how to treat their tumour. In cancer care, we have a score called the performance score. This gives us a measure of what people can do. For example, can they work? Can they dress themselves? Or do they need help going to the toilet, etc.? In many research studies, this performance score has been found to correlate with how long people live after treatment. Some people use this score as an indicator of quality of life, saying that being unable to walk or dress must mean a poor quality of life. I found that quality of life doesn't always equal how intact someone is neurologically, and we all see this with the amazing Paralympics. We have other scores like the Glasgow Coma score, which is used to measure conscious level, but I think we should have a Walton happiness score or a Liverpool happiness score. A high score indicates someone who is happy, whatever happens, a sort of Ryan Reynolds type person, whilst a low score might be someone who's miserable most of the time, like the painter Vincent van Gogh. I think you all know examples of both types. Let me give you a couple of examples. I always remember a man whom I'm going to call Neil. I met him as a senior trainee. Neil was admitted under my consultant at the time and was having his fourth operation on a spinal tumour. It was benign, but it was wrapped around the top of his spine and kept returning after surgery and treatment. After his last operation, Neil was left unable to move his arms and legs or even breathe on his own. He became completely paralysed and ventilator dependent. He spent more than 6 months on our ITU until he was eventually sent to a long-term ventilation unit. How could anyone remain happy after this, you may ask? Well, like the famous actor Christopher Reeves, I think it's more about how you can remain positive even when it may seem you've lost everything. I met Neil a year after his discharge from Horsley ITU when he came back to clinic with his partner. He came in an electric wheelchair with a ventilator underneath. He could control the wheelchair with his mouth. He told me of his trips to the cinema, the theatre. He enjoyed both. He went out to parks. He could read. And despite such desperate disability, enjoyed his life and enjoyed every day he had. He'd score high on our Walton's happiness score. I'm sure he had setbacks and down periods, and despite never meeting him again after that clinic, I never forgot that man. Shortly after meeting Neil, I met John. John was 35, married with a young child. John had a seizure and had been found to have a low-grade glioma, one of those slow-growing tumours. He'd already had some surgery and radiotherapy. John's tumour was stable and his seizures were well controlled. John wanted me to remove his tumour. I couldn't remove enough of his tumour to make a difference given where it was in his brain. Every clinic appointment would consist of going over the facts about his tumour again and again. We would discuss how the tumour invades the surrounding brain, that we cannot see the edges, either surgically or on imaging. However aggressively we treat the tumour, there are likely to be tumour cells that will grow in the future. If we went ahead with surgery, what he wanted, it would give him a significant disability. In spite of that, even with surgery, John's tumour would still come back. He couldn't accept this. John spent his evenings scanning the internet for cures, requesting second, third, fourth, 20th opinions to treat his tumour. He would then come to me and we would talk again at length. He never accepted his condition, that we couldn't cure it, even though he had no neurological deficit and his seizures were well controlled. Unfortunately, John never did find a cure or his peace. John would have scored low on our Walton's happiness score. In scientific meetings, we talk how to treat the tumour, the symptoms and any clinical trials of new treatments that could let people live a bit longer. The British way is often to just get on with it. What we are less good at is sometimes helping people cope, or as the brain tumours say, living well with a brain tumour. My wife Catherine is an anaesthetist. We have 3 children. One of them is actually on the call today. I've already mentioned that I get no sympathy. Our children also get no sympathy from either of us. We both see people in such dreadful situations every day with so much disability. What's a bit of bruising, vomiting, or a broken limb compared to somebody who cannot speak or has an incurable brain tumour? Amazingly, despite this, our children have all survived to adulthood. I know I said at the beginning this was about Walton stories, but I wanted to talk a little bit about Nigeria, a little bit how it's very different but the same in many ways. I've visited Nigeria twice in the last couple of years. Dr. Baba Aji, who is one of our neurologists, comes from the northeast of the country from a city called Maiduguri. This is where I visited with him. You may have seen the city in the news yesterday as they had 3 bombs go off in the city killing 23 people. It's thought this may be the work of the terrorist organization Boko Haram. One of these bombs went off in the hospital complex. There were no casualties at the hospital, thankfully, but they've had to deal with more than 70 injured patients that require inpatient treatment. Our visits have been to help with their plan to build a new stroke and neuroscience centre. The Walton Centre has kindly donated old second-hand equipment, which has been extremely helpful in equipping parts of this centre. The people there are extremely welcoming and very poor. The hospital is federally funded, which means it's subsidised but still costs a lot of money to ordinary people, and this comes to play in clinical decisions. When I was last there, we met a patient called Ahmed who had a malignant brain tumour. It had affected his behaviour, it was quite big and in his frontal lobe. He had little drive to do anything. He would sit in the corner, he wouldn't do his work, he really didn't want to do anything. The discussion, as is the custom, was with the family, although Ahmed was in the room as well. The local neurosurgeons, I suggested he might benefit from surgery to get a diagnosis and at least allow him to have further treatment. They wanted to know if it would make him better. No was the answer. The view of the family was that it was a lot of money for them to pay, um, and they could not afford this. And if he was not going to help, if he was not going to help him make it better, they couldn't afford this. So he wasn't treated. And you think that's dreadful. That's really sad that happens. In the UK, 20% of patients with a primary brain cancer get no treatment, and a further 17% get surgery but no further treatment, with a prognosis as if they had not had surgery or of only a few months. We have a best supportive care clinic at Walton, one of the very few in the country, where we meet and talk to these patients and their family as we did with Ahmed. Treatment for the sake of treatment is not always the right thing to do, and we are lucky in this country that money is less important in helping deciding what is right for the patient. I'd like to talk a little bit about language. So language is an interesting ability in the brain. There are two main areas of your brain that deal with language, and there are connections between them. One area finds the words for what you want to say, and the other understands what is said and what you say to self. It's not quite as simple as that, but it's along those lines. Most right-handed people have their language centers on the left side, and whilst this is also true of left-handed people, lefties are also more likely to have language on the right. Bilingual or multilingual people can have a more complicated setup where different languages are in different areas of the brain. In oncological surgery, we think a lot about language. We'll often operate with the patient awake. We do this because it's the most sensitive way to know exactly where the language area is and to try and protect it. However, it doesn't guarantee that it will preserve speech. Many of you may have seen Mr. Olabaju's presentation on awake surgery, and if you haven't, I'd strongly recommend you watch him for more details. I want to think about awake surgery slightly differently. Today we've spoken about the psychological implications of having a tumour. There are also psychological implications of having awake surgery. Most people cope extremely well, although I had one patient who had post-traumatic stress disorder. She would have flashbacks when she was asleep that would wake her during the night. She did see a counsellor, but it took a further 2 years for her to get over the experience. On the other hand, I've even had a man who told me afterwards that he enjoyed watching the whole thing on the TV screen in theatre. Unbeknown to me, the theatre team had set up the monitors for the scrub nurse to be able to see what was going on, and much to this man's delight, it was visible in the periphery of his vision. All I can say is I'm glad he enjoyed the show. In the surgical management of tumours, we think of progress as being able to operate earlier, being more aggressive and taking more of the tumour away. Sometimes the unexpected happens. Jack was 20 and he had a scan after a minor head injury. A small spot of something different was found in his right frontal lobe. He had no symptoms and was training to be a nurse. I explained to Jack that we cannot always tell that what these things are on a scan. When I first started seeing people with vaguely defined abnormalities on a scan, I'd always offer to remove them if it could be done safely. After a while, and having a number of pathologists tell me that the tissue I sent them was normal, although I had evidence that I'd removed the entirety of the abnormal area, I became much more conservative. I explained this to Jack and we agreed to watch. The underlying worry that this was a glioma. A glioma is, simply speaking, a tumour made up of cells that look like the supporting cells of the brain. They can grow or become cancerous in the future. That is quite a big deal for a 20-year-old. Jack, however, took it in his stride and kept on meeting every 6 months, then every year, and he finished his training as a nurse and started working. Each time we spoke about surgery, because unlike some of our early stories, this was a low-risk operation. Many people can do without parts of their right frontal lobe, and you wouldn't know the difference. After a few years, it started growing a bit. It wasn't a good time for Jack to have surgery. He had just moved jobs and he wanted to work a bit longer before we did anything. It grew a little bit more. We talked about surgery again, and I realized he was left-handed. We did an fMRI scan, a functional magnetic resonance scan, a type of MR scan that can identify where the eloquent areas of the brain are, like speech. He was one of the few people who has speech on his right side, and it was exactly where his tumour was. So much for me thinking this was a low-risk operation. We spoke again about it, but he wasn't ready for awake surgery. We watched a little longer, and it grew bigger. By this time, it had been 8 years since we first met, and this had overshadowed his entire adult life. Always that thought that this could turn cancerous and end his life prematurely. He agreed it was finally time for surgery. It had been a few months since his last scan, so I got an updated scan for theatre. The area we worried was a tumour had almost gone completely. The consultation was a bit surreal. He was shocked as he had finally got his head around having surgery for this thing, and now it was gone. I was feeling grateful that it had gone, a bit mystified, but also concerned that had he made a decision 6 months earlier, he might have ended up with what had been an unnecessary operation. I saw him once more as I did one more scan just to make sure. The area was gone completely. Jack was happy and discharged. Admittedly, a finding of an abnormality scan done for other reasons is getting more common, but to have something that we worried might be a tumour which slowly gets bigger and then disappears is thankfully very rare. People have different ways of dealing with their tumour. Stacey never said very much when I saw her. She was in her 20s and had a degree of autism. She would sometimes answer yes or no, but mostly she sat there, looked at her dad, and he would answer my questions. She liked animals and had several named hamsters and rats at home that she looked after. She had a low-grade glioma that needed surgery, and we needed to do it awake. She seemed to take it in her stride, and surgery went well. I was able to get most of the tumour out. I've seen her regularly since, and we've been watching her with scans. She still doesn't say very much. I however discovered that she has much more to her than meets the eye. She has a sense of humour. She has a selection of craniotomy t-shirts, amazingly enough, which she wears. When we do the surgery for for people, we have to draw an arrow on the correct side of the head. It's part of the World Health Organization checklist. She had a photo of that taken, and she had that tattooed on her head exactly where it was prior to surgery. I'm not an expert on tattoos, but I've never seen that done before. She also writes poems which she sends us, which I think helps her come to terms with what's happened. I'm going to read a part of one now which she wrote after a 1-year follow-up. Today marks a year since the awake craniotomy. My world turned upside down, not part of my plan. As the fear and the shock cut deep to the core, a path I had never walked down before. Through diagnosis wait, through surgery's test, an awake craniotomy put me to the quest. But courage was found in the darkest of night, and love held me steady and guided me right. To Tara, my family, my true friends who stayed, through shadows and sunshine, through fear, unafraid. You lifted me high when I thought I would fall. Your love was my anchor, my strength through it all. So today's not just when most of my tumour took flight. It's a beacon of survival, of courage, of light. A story of strength and the love I've been shown. 1 year ungrateful, alive, never alone. Many patients make an impression on us, and sometimes we make an impression on them. Felicity's in her 30s. When she was a child, she had a malignant brain tumour that needed surgery and radiotherapy. Whilst the treatment cured the cancer, it left her with the educational level of a small child. It also predisposed her to develop further tumours. I met her because the radiotherapy made her develop multiple meningiomas, which are tumours that grow from the surface lining of the brain. I've operated on her twice when they got big enough to start causing her symptoms. The second time she had an infection and had to stay in hospital longer as she was on an extended course of antibiotics. People worry about the long-term effects of treatment on these children as it can leave them so disabled. If I were to grade her on my imaginary Walton happiness score, she would score highly. She is ably looked after by her mother and sister. She's so loved in that family, it comes through whenever I speak to them. She likes colouring, having her nails painted, singing and collecting handbags. She does say some things, but she only says one thing when she sees me. She looks at me, concentrates, and then says, "Doctor, when home?" Every day when I saw her, she would say, "Doctor, when home?" Didn't matter what I'd said the previous day, and this continued every day for the week she was an inpatient. At the end, she insisted we have a selfie together, probably breaking the odd infection control rule. She went home. I often move people by video as Felicity lives quite far away, and saw her 6 months later in her living room with her mum and sister. She was well. She'd done very well. Her wound had all healed. And there, over her head, framed and hanging on the wall in the middle of the living room, was a photo of us both. Sometimes I start to feel like I know what I'm doing, then I have a patient. I saw Jane in clinic. Jane wanted to be a skydiving instructor. Jane had a cyst in her brain, which was incidentally found after a fall. I reassured her. "These almost never cause problems," I said. "It is rare that anyone needs surgery," I said. I arranged for a further scan 3 months later to reassure both of us. The scan showed it bled a small amount, not enough that she needed something doing. "This may be all it does," I said. "These are unlikely to bleed much," I said. "See you in 6 months," I said. Less than 3 months later, she was back in A&E. She was getting weak down her right side. There was more blood in the cyst, a lot more, causing a lot of pressure on her motor cortex, which is the bit of brain that moves her right side. Okay, I said, we need to operate. At surgery, it all came out as blood clot and other bits, impossible to say what anything was. It all went to the helpful Buxton labs, and they told me it was a cavernoma. A cavernoma is like an abnormal collection of blood vessels, and when you operate, it can look like a raspberry. They can bleed, usually only very small amounts. Once you've removed it, it should be gone. Jane got better. She went home. I saw her 6 months later, and she was better. She wanted to know when she could do a skydiving jump again. Skydiving is not forgiving if you have a seizure, so I thought it needed to be a bit longer. The time came and went. I got a message from my secretary. Jane wants to go do a skydive to raise money for the Walton Centre. Excellent, I said. She must be better. I thought, she wants you to do one as well. Oh, I said. I'd never really thought about doing a skydive before. People I spoke to were mainly in two camps. No way. And oh, I've always wanted to do one of those. And then there was my colleague neurosurgical experience. Yes, I've done a lot of them. They're okay. Eventually I said okay, and Selina, one of our nurse specialists, agreed to do it as well. Between us, we were able to raise a bit of money for the trust. The day of the jump arrived. It was beautiful. We went up near Blackpool to a field with a bit of tarmac and a slightly rickety plane that would take off and then come back down and land continuously throughout the day. Eventually it was our turn. There were four of us, including Jane. Well, Jane and Selina were fine. I fell out the plane in a tumble with the instructor. I was glad there was an experienced, no-nonsense instructor there, and what a rush. It was beautiful, exhilarating, such a view. When the instructor has faith in you, or you are more experienced, you land standing up. So I landed on my bottom, and unbeknownst to me, shredded my trousers in the process. At the end, after some more photos and getting rid of my harness, I walked back to the car feeling slightly pleased with myself, whilst unknowing exposing my bottom to the world. I've been involved with filming for the TV on a few occasions over the years. I always think it's exceptionally brave of patients to allow the film crew to follow them at what is probably the worst and most stressful part of their lives. I've done it because I think it's important to highlight what we do, and in what I mean both in surgery and at Walton. However, having a film crew in theatre does up the stress level. You cannot predict how surgery will go, and it's one thing having a complication on your conscience, it's another to have it broadcast forevermore on reruns of Channel 5. Being filmed does, however, give my wife much amusement at some of the things I say. Watching it afterwards is the worst, though. Wow, did I really say that? Do I always operate with so much blood? And doesn't Professor Jenkinson come across well? Treatment is about so much more than an operation. Lana was American. She lived in the UK and had a high-powered job in the legal profession. She had seen one of our neurologists with severe migraine that was persistent, and a scan had been carried out. The scan showed an incidental finding of a tumour in her medulla. The medulla is a part of the brain stem at the top of the spinal cord which connects everything in the brain with the rest of the body. The medulla is also important for things like breathing, your heart rate, swallowing, and other important stuff. The abnormality looked like a tumour, but our radiologists disagreed amongst themselves as to exactly what it was. Depending on the diagnosis, the treatment would be very different, or she might need no treatment at all. We talked about what to do, and as she had no symptoms, we started by watching it. I was hoping it would go away. It didn't. It started to slowly get bigger. I was nervous about operating, and occupied at least half of the medulla and was within rather than growing out of the brain. I was worried I would cause Lana significant damage, even leading to things like a permanent tracheostomy or being in a wheelchair. We watched over a few months and eventually got to the point we could no longer ignore it. Because of my reservations, we agreed that a biopsy might be best so that we could know what it was and see what treatment options might be available. A biopsy of this tumour involved opening the back of the head as if you were doing the bigger operation, but it can still take a couple of hours. On the day when we reached the tumour, I was surprised to see that it was very distinct from the surrounding brain, suggesting it was not infiltrating, but rather the pushing the brain out of the way. An intraoperative smear suggested this was a type of tumour that if you can remove it, it can be curable. But if you don't, it can be life-threatening. I proceeded to remove it. The tumour came out well. I was able to preserve all the surrounding brain as far as I could see. Weirdly enough, one of the most stressful things I find is not doing the operation, although that can be challenging. It's waiting for them to wake up once I've done the op. That is stressful. Will they wake up? Have they bled between me closing and now? Will they be able to move, to talk? Was that tiny artery or vein I had to take, cauterize, important? If they're weak, will they still be weak tomorrow or next week? Do I need to scan them to check? I've lived many lifetimes of worry in the time between finishing the operation and the patient waking up, and that time with Lana was one of the worst. Thankfully, she woke up well. She could move everything, could mostly swallow and breathe and talk, a success from a neurosurgical point of view. Post-op scanning suggested I'd removed all the tumour. Meg had some numbness down one side of her body. She went home. Over 6 months, this slowly became painful. She needed some drugs to try and help her symptoms. I reviewed her regularly. I saw her almost a year after operation, and I was shocked. She put on a lot of weight. She was really struggling. She was exhausted all the time with a lot of pain down one side and was unable to get back to work. I checked all the things in her blood that might be giving her fatigue and reassured her that it should get better, but it didn't. Our specialist nurses and AHPs provide a service for patients with fatigue, and they saw her and worked with her. She slowly improved. This took some time and a lot of work on her part. I've seen her again recently. She still has symptoms, but she's coping with them. She's started back at work. Her tumour remains under control, with no evidence of anything abnormal on her scan. Despite how long it has taken for her to really get over this, she remains positive and thankful for her treatment. However good the scan looks, or however pleased you are with your operation as a surgeon, for surgery to be truly successful, there is much more to it than that. There's a book by an American neurosurgeon entitled When the Air Hits Your Brain. The book describes several rules. One is that you're never the same after the air hits your brain, and another is there's no such thing as a minor operation in neurosurgery. I think both are true. To have a successful operation, you need the cooperation and drive of the patient to get better, a team around you to help and support them. People cope in different ways, be it tattoos, photos, poems, family support, or just sheer willpower, but this remains a team effort. I've seen some people with extreme conditions over the years. I had a patient with a tumour eroding through her skull who'd hid it by having a large fringe because she didn't want to go to the doctor. I had a lady with a cystic spinal tumour that was so large and had been growing unknowingly for so long, it was occupying more than 2/3 of her chest and was pressing on her lungs, making it difficult for her to breathe. I've had people at rest during surgery, and after successful resuscitation, we've continued and finished the operation. I've had people with things like pitchforks or plugs stuck in their head after falling. Despite this, I think it's the people behind the conditions that are the most interesting, and hopefully you found some of what I've said interesting today. I retire at the beginning of April. Whilst I'm planning to keep up with some of my academic, what it is, and teaching commitments, I'm giving up my clinical work. I'll miss the clinical team, the staff, the challenge of the job, but most of all, I miss the patients. I'm happy to take any questions.
Thanks, Andy. I mean, I thoroughly enjoyed that, and I'm sure everyone, all 84 people on the call, did too. So if anyone does have any questions or comments that they'd like to make, by all means. Amanda, I see you've got your hand straight up. Go on.
Hiya, can you hear me?
Yeah.
Oh, super. Hello, Andy. Thank you so much. That was amazing. I'm just fascinated about the nurse that had the glioma that wasn't. Do you know what it actually was? Did you ever find out what it actually was?
It disappeared. It just went away, and to disappear after 8 years, that's just weird. But we see more and more people having incidental findings on scans. And you don't know what to do. We're taught if you've got a glioma, we want to treat it aggressively. You want to take it out as quickly as possible and get rid of as much of it as possible. But yeah, it's not always the right thing to do.
Had you done a biopsy before at all, or did you just go in based on the scan?
For the nurse, no, that we didn't treat them at all. I didn't do a biopsy. I didn't do any operation. It disappeared before we did anything. But it took 8 years to get to that point.
Wow. Thank you.
Joanne, go ahead.
Oh, hi. Thanks very much for that, Andy. It's been really insightful for me. I'm a new governor, so it's really important for me to understand the patients at the Walton Centre, but I'm also a non-clinical NHS employee, and it was lovely to hear the worry and concern that you have after operations, because I think as non-clinical staff, we do put all you clinical people on pedestals and think that you cope really well, and you're invincible almost. So it was absolutely lovely for me to hear that you do have those kinds of worries and concerns, and I'm sure you all do, but it's nice to actually hear it, because I sometimes don't think we realise that. So thank you so much for that insightful information. Thank you.
Yeah, no, it's pretty scary. I mean, thankfully, I have good colleagues, good people we talk to. We talk a lot about things amongst the surgeons, amongst the nurse specialists. It's a good supportive community, which helps, and a lot of experience, which is helpful. Thank you.
Thanks, Joanne. Can't necessarily see anyone else's hand up, Andy, which is, I don't
Okay.
think I can. If anyone, oh, here we go,
Oh,
Farouk. Go ahead,
oh,
Farouk.
fantastic. I gave you a plug, Mr. Olabaju.
Thanks for the plug. I suppose my question for you is if you could, now that you've come to the end of your career, if you could go back and give that young Andy Brodbelt back in the day, like, a long, long time ago, some advice, what would you give him in terms of what to focus on? I suppose it's kind of, what would you tell a young budding neurosurgeon about their career in neurosurgery?
Yeah, I guess keep going, that it can be hard at times, but if you focus on what's right, you've always got to have the patient at the center of what you do. Not you, not somebody else, not the management, not the costs. The patient has to be at the center of what you do. And if you keep that as the basis of how you decide, how you structure what you do, then I think you go right.
Awesome.
Thank you for.
Thank you.
Okay,
Sorry, Nicola, it wasn't as long as you. I spoke too quickly, didn't I? I
It's
looked up how long it was
listen,
going to take. So
it's absolutely fine, Andy. I'd expect nothing less. Gary, go ahead.
Hi, Prof. Great talk, as always.
thanks, Gary.
I suppose two questions. Is there a book in this? When's the memoir due? You mentioned some other books out there. And where do you see, I guess, neurosurgery going in the kind of, well, short term and long term, both at Walton and sort of internationally, I guess?
Book? Oh, I don't know. It was really hard writing this. I'm not sure that's quite book material yet. As far as where's neurosurgery going, neurosurgery is interesting because it's always changing. It's always developing. There's always new stuff coming in, and the new guys like Mr. Olabaju push the old guys like me into doing things that we haven't done before so much or didn't like doing so much before. What will happen? I remember when ISAT came out. So ISAT was a study looking at the treatment of brain aneurysms, and it suggested that people were a little bit safer having it treated by going into the blood vessels rather than having it operated on. And that changed practice overnight. We went from clipping loads and loads of aneurysms to clipping almost none. And I think those sort of things often happen in neurosurgery. And I can see neuro-oncology changing in the future. Surgery is not the future of neuro-oncology. To be honest, one of the medical directors here told me that 20 years ago when I started. We do more now in neuro-oncology than we've ever done. We're more aggressive. We've got more kit, more stuff to do in neuro-oncology. But I would agree, it's not going to cure the disease. The disease has to be hit at a cellular level somehow. Now, surgery may still be a part of that, but it's not the cure. So in oncology, I think it's going to be other things. Chemotherapy, radiotherapy is a pretty aggressive treatment. It's going to be chemotherapy and more targeted areas of surgery to get what you need in there. As far as other things, I guess, robotic surgery, we've looked at some robots here and some look really cool, but they don't do very much. They're basically glorified pointers at the moment. Maybe, neurosurgical robotics might be something in the future. There's all sorts of stuff. I think there's a lot of interest from the rehabilitation point of view of stimulators, on the brain for people who have disability to get them walking, moving. We've seen films like Avatar with people, those special suits that do. So I think people with disability, giving them more ability to do things will be one thing. But from a surgical point of view, I think there's a lot to come in functional neurosurgery and a big change to oncology neurosurgery in the future. That might be 5 years, that might be 20 years, that might be 50 years. Don't know.
We've got John. Go ahead, John.
Thanks, Andy. That was a really good talk. And I think your advice to put patients first is good for any doctor, although it's sometimes difficult because we've got targets and all the rest of it. If it may say so, you don't look old enough to retire. What are you going to do in retirement? Because the first week can be fantastic. The second week's all right, but the third week onwards can be a bit of a challenge. So how are you going to use up your time?
Oh, I got loads. I can't sit still, John. So, yeah, no. I don't think there'll be much of a problem. So I've still got teaching stuff. I'm an examiner for the Royal College for Neurosurgery. I'm president of a national charity called the British Neuro-Oncology Society. So I'm heavily involved in that. I'm gonna I've got a few papers that I've wanted to write but haven't been able to write up till now. And so, yeah, I've got plenty of things to keep me going from both the sort of intellectual point of view, as well as I like doing a lot of fitness stuff and, you know, woodwork and 3D printing and things. So I got plenty to occupy my time that still involves a bit of intellectual work. Thank you for the question.
And next we've got Ian McDonald.
Hi, Andy. I just wanted to express my thanks 19 years after you first met my wife, who is still alive and enjoying a quality of life. And it was down to the love of you and your team that brought her through that. So I just wanted to express those thoughts and thank you.
Oh, you're very welcome. Ian, what is your wife's name? Oh, I've lost him.
Yeah, I don't know whether he may still be there. I don't see.
Sorry.
He can come back in at any time if he's still there.
Okay.
Just wonder what your wife's name was.
Christine.
Or is it Christine?
Christine.
Okay. Oh, that's really good to hear. Thank you. Thank you for
Yeah.
sharing that.
She had a diffuse tumor that took 6 months to identify. So, but thank you for everything you did.
Oh, you're very welcome.
Don't think I can see any other hands up, but I do have a question for you, Andy. What will you miss most about working in the Walton Centre?
Obviously you, Nicola.
Well, see, I'm glad I got this on record.
No, look, there's a lot of good things here. Really is. There's a lot of good people. I enjoy working with the people here, but you know, you can see from the stories, it's the people we get to look after, and it's being a part of their lives. You know, one of the things about treating people with brain tumors is you look after people over quite a long time. I've got patients that I've been seeing over 20 years. And even if it's only a few years, you're a big part of them, and you see how they grow and change and mature over time, and that's been really nice to see. So for me, number one, working with people, patients, but absolutely right up there is the teams we've got and the people we've worked with over time. And you, obviously, that they're 2 and 3.
And yeah, okay, good. Just so everyone knows on this call, by the way. Does anyone else have any questions that they can think of? Irene, go ahead.
Thanks, Nicola. Just wanted to say, Andy, that was a really, really fascinating talk, and listening about all the experiences that you've had and all the different people that you've treated and the different outcomes. With such a long and illustrious career, I just wondered, was there any kind of standout moment that you felt particularly proud of through all of that wonderful work that you've done? And also any particular challenging moment that kind of stood out for you in your career?
I think some of them are presented today. So look, seeing my picture behind that young woman's living room, wow, it was so nice. She's so lovely. And so yeah, things like that are nice. There's been lots of absolutely scary, heart sink moments over the years. Neurosurgery is like that. You know, if you're operating on somebody and their heart stops, and you have to resuscitate them or do other things, that is just dreadful. Or you're struggling to control the bleeding, or you suddenly start a case and you realize that it's a lot more difficult than you thought it was going to be, and then you're struggling. Yeah, there's lots of them. I'm not sure I can pick out one particular, Irene, but there's been regular things over the years that have kept me on my toes. But yeah, so yeah, there's a lot of things. I suppose what's always nice is it's the thanks from the patient, like with Ian today, and with hearing that people have done well is always nice.
That's amazing. Thanks, Andy. Really fascinating to hear the story. Thank you.
Okay then. Well, what we can do, rather than keeping everyone on here and pressuring anyone to ask any questions, if anyone does have any questions, I think everyone pretty much has my email address now. You can drop me an email and I'll forward them on to Andy. I'm sure he'll be more than happy to answer them and we'll respond that way for you. I do have one last request from everyone. I'm just going to share my screen again quickly. For all of our virtual events, we do gather some feedback as well. I will send this around to everybody who's joined the call today. And if you would be able to fill in the short feedback form, it only take a couple of seconds to fill in. But that way I can share the feedback with Andy on this event and it'll help me to be able to plan future events and tailor future events for our viewers' needs. But once again, thank you everyone for joining today. And just to get this on record as well, this is the highest attended event that we've had. I know Farouk will probably be sitting there rolling his eyes. I'm sorry. But yeah, the amount of interest we've had in this event was like phenomenal. So thank you everyone. And thanks, Andy. Really appreciated. Thanks everyone.
Thanks,
Andy. Cheers.
Thank you. Bye.
Bye bye.
Thank you.
Bye. Thank you. Thank you very much. That's brilliant. Thank you.
You're welcome.